Thank you. Morning, everyone. So, we're going to talk for about an hour or so, 45 minutes on AMD. Going to give you an overview of the problem, the challenges, the different classifications about referrals and OCTs and developments and interesting things that are in the pipeline that might be coming to help us deal with AMD in the future. So we all know, hopefully, what it is. It's an age-related condition causing degeneration in the retina or the macula at the back of the eye, and it's increasing in prevalence because it's okay. Because of the the much documented aging population, you have more and more people living longer and developing age changes, particularly macular degeneration. So it used to be that glaucoma was the big beast in most eye departments. That was the one that took up all the resources, all the manpower. And actually, over the last 5 to 10 years, AMD has overtaken it. So certainly in Sussex Eye Hospital where I work, it's by far the biggest service. It's bigger than the glaucoma service now. There are more people to treat because they're living longer. There are more people developing the disease. We're better at detecting it. And also we've got treatments for wet AMD, which we didn't have 10, 15 years ago. So it's an increasing challenge, definitely. And as you can see on there, about 600,000 people have got sight loss or sight impairment caused by AMD in the UK at the moment, but that's predicted to be well over 1 million in about sort of 20 or 30 years' time. So it's a significant challenge for us, and obviously people with sight impairment, there's a significant knock-on to society about that, as well as impacting their lives generally. The dry type is much more common than the wet type, which is like a gradual deterioration in vision, whereas the wet type is that sudden onset change, although patients often don't notice it in the one eye, because if the other eye is still good, it masks the effect of it. And if we're looking at a definition of it, we're looking at drusen changes under the RPE. And those drusen changes, which we've all hopefully seen or know about at some point, they're really important because they cause disruption to the RPE complex. And the RPE complex is the thing that nourishes and looks after your photoreceptors. So if you start to break that RPE complex down, it doesn't work so well, your photoreceptors will start to die. So gradually over time, you'll get an accelerated loss of photoreceptors. So there's two stages. There's an early stage where you basically got normal vision. You might be slightly reduced, 6.75, 6.9, but it's a normal level of vision that the patient has. They might have some small drusen, they might have some pigmentary changes, but generally they're functioning fairly normally. They might say it's not as good as it was, but they're still above driving standard. Often they can read, they're just maybe not quite as sharp as they were previously. The larger the drusen, the larger the area affected, the more hyperpigmentation changes covering the retina, the more likely they are to develop AMD problems later on. And there are two types of that, as I said. And in the late stage, you've got the dry atrophic changes that happen, which affects 25%, and then you can get the wet type, which is the rapid onset one that drops. And you can see the figures have switched around there. In the late stage, it's much more of the wet type than the dry type. That's good because we've got a treatment for the wet type. We don't particularly have a treatment for the dry type at the moment. But it brings its own challenges in, if all those patients need injections in their eyes every 4 to 6 weeks, that's a significant burden that we as a healthcare system have to deal with. It's a real challenge delivering, seeing all the new referrals and then going ongoing treatment. And ongoing treatment can be, some people need 3 injections, some people need 53 injections. So, they can be coming back and forth to the eye hospital for years and years and years, having injections every 4 or 6 weeks. So it's a significant challenge. It's great we've got a treatment, but it's a big challenge to look after them. So normal eyes, a normal eye with, no signs of AMD or some very small, discrete drusen. So I'll talk about the drusen a bit more because the drusen are actually really important in AMD and its development. And there's some really interesting work looking at different types of drusen and actually how it's related to the choroidal thickness underneath the retina, which can influence the subtypes of wet AMD that you can get as a result of these drusen. But small hard drusen are less than 63 microns. So who knows what 63 microns is? So has anybody got an idea? It's a random figure, right? A human hair is about 75 microns. So a small drusen is smaller than that. But that's not a great reference if you're looking in the eye because you haven't got a human hair in the eye. Well, I haven't got any to look at anyway. But the central retinal vein is about 120 microns, okay? So it's probably about half the thickness of that is what's classed as a small, discrete little hard drusen. And then we tend to classify it. So if we get patients that we're seeing in community or in the hospital, we'll classify it on sort of low risk, medium risk, and high risk, okay? And that depends, again, like I said in that first slide, on the size of the drusen, the area that's covered by the drusen, whether there's pigmentary changes with it, whether there's reticular drusen, where it's a slightly different appearance type of drusen, very easily diagnosed with an OCT, or you've got some vitelliform changes, or in the really high risk stuff, if they've got atrophy. And that's interesting with the atrophy because there are some really interesting things I'll talk at the end, but there's some studies going on at the moment looking at limiting atrophy through drug treatment, not just through, oh, well, you've got atrophy, that's it, we can't do anything anymore. So the size of the drusen, so large drusen, over 125 microns, so again, thickness of that central retinal vein, and if you've got drusen and pigmentary changes and lots of them together, it does make a significant risk factor for that patient. So, good examples of sort of medium intermediate, if you like. So on this one over here, we've got, you can see lots of confluent big drusen in the middle. You can look at them if you think, comparing them to the central retinal vein. They're obviously much wider than that, so it's quite a big area of confluent drusen. So medium to sort of high risk on that one. And then that one, they're not so big, but it's obviously a very large area of the retina that's disrupted. And you've actually got some pigmentary changes as well. So it would make it more of a risk factor for these particular patients when you look at them. AMD, so if you get to the late AMD and the dry type with the geographic atrophy I've just discussed, so geographic atrophy is dry, there's no wet AMD, there's no neovascular component to it, it's just an inflammatory atrophic process that's happened over time, okay? It's heavily linked to complement pathway, which is an immune response, and it causes inflammation in the retina, in the RPE, and gradually progresses the geographic atrophy over time. And you can see this image on the left here. That's a big, large patch of geographic atrophy. And unfortunately, it's slap bang right in the middle of the fovea, which is where all your good vision is, where you can't see. So the vision in this patient will be severely impaired as a result of it. So, and in terms of classification, the wet type, so we've got wet AMD, which is probably what all of us are aware of. There are actually 4 or 5 different subtypes of that. So when it comes in for a diagnosis, we will then look at certain key points to work out which type of wet AMD it is. And the reason we do that is because they're treated in different ways and they respond in different ways, okay? So you've got the two classic, there's a classic and occult with the original diagnoses, if you like. And the classic is probably the more common, I suppose. The occult is... So I guess the difference is the classic is that the blood vessel, the choroidal membrane, has grown through the RPE into the retina, and the occult membrane sits under the RPE. So it's a bit harder to detect. It doesn't leak in quite the same way when you run it through some tests. You can have a mixed form of it. You can also have a wrap. So does everybody know what a wrap is? Anybody come across a wrap before? No? Okay, so a wrap is the wrong way around. Most wet AMD is coming from the choroid and coming through the retina. A wrap is a funny retinal vessel that grows down into the choroid. So it's the wrong way around, okay? But they respond really well to injections. You'll need to give them 1 or 2 usually, and it dries it up completely. So a wrap is a really, actually it's more common than we realized, and polypoidal choroidal vasculopathy, which again looks like wet AMD, but actually it's a little polyp on one of the blood vessels in the choroid that leaks, okay? So actually you can inject it and it will help get rid of the fluid, but it'll still keep leaking. So you actually have to laser that patient. So injections help, but you need to laser them often to get rid of the polyp. Otherwise it just keeps leaking and leaking and leaking. So going back to what I was talking about earlier, if you've got a patient who's having 20 or 30 injections, so it's not really responding, you'd sometimes stop and go, hang on, something's not quite right here. Let's reevaluate what we're doing and go looking for polyps to see whether there's a polyp underneath. And they're little grape-like things that sit on the blood vessel. So if you use an ICG dye test where you inject indocyanide green into your veins and then do a lot of photographs, you can see them just light up in the choroidal network underneath. And in the late stage, you've got wet inactive. So these are patients who possibly have had it in one eye for a long time without realizing it, okay? So they've got fibrous scarring, they've got all sorts of, when you look at it with a Volk lens with 3D, it's just big mound of fibrous tissue in there. Or if you scan it, you can see there's all sorts of the scan just looks really awful, really bad. You can think, well, this patient can't see. But there's no active leaking going on. So you often get these if they've been unaware of it. So you get people often turn up at the eye hospital with a referral for this, and they say, well, I only noticed it last month. It's probably been there for about 2 or 3 years, okay, because the other eye's covered up for it, which is quite not common, but people don't turn up with it often. Or the other side of it is some of those patients over time have had repeated injections, but they've still ended up with a fibrous scar because there's just been every time you get a bit of fluid leaking and a bit of wet AMD, it kills some photoreceptors. So if you have enough of that happen repeatedly over time, you'll end up with a scar formation of fibrous tissue forming. It's just so you've held the disease, but not actually cured it, and actually you're getting little bits of damage every time it happens. So there's the inactive wet type, and actually they can still develop fluid afterwards, although if their vision's below a certain level, we don't tend to treat because functionally the scan might look better, but actually in reality, you're not going to make any practical difference to their vision. So if you put that into sort of summary, we've got normal eye at the top, and then early AMD, so classic drusen, which probably is where optometry fits into this picture particularly, or opticians' practices. Then you can either develop to the wet AMD, which is probably about 20% of them, and that can form a scar even with treatment. Hopefully, if we get it in timely manner, then we can stop that forming. Or they'll develop the geographic atrophy, which is the dry version. Both of those things, unfortunately, end up with severe sight impairment or sight impairment. And ideally, we don't want to get anywhere near that. Ideally, we want to intervene somewhere, whether it be through good patient education, diet advice, nutrition, supplements, whatever it is, when they're at risk, or appropriate fast-track referrals into eye hospitals so they can be treated in a timely manner to prevent the wet AMD progressing even farther. Let's get rid of the figures. So OCT has become much more widespread in optometry practices, particularly in the UK, although I think Australia and New Zealand have rolled it out quite a lot now as well. And so optometry, again, or opticians' practices are a good place to use OCT to help interpret and refine referrals with patients who have potentially got AMD problems. So everybody familiar with OCT? Everybody use one regularly? Yeah, pretty good with it? Yeah, so obviously you've got the scan over on the on the right-hand side there. That's a normal-looking fundus. The OCT gives us amazing detail. It gives us a level of detail we've never had before. So some of the really good OCTs go down to 5 microns in ability to resolution. Okay, so if you remember, the human hair is about 75, central retinal vein 120. These are down to 5 microns. It's an incredible level of detail we can pick up on these machines to help us diagnose things. In terms of AMD, particularly we're looking at those tram lines at the bottom, the thick white lines. They're the really important things that we need to look at in terms of AMD if we're helping things out. So the 2 really thick ones at the bottom, that's your RPE complex. That's the retinal pigment epithelium complex. That forms a retinochoroid barrier, but also nourishes and supports the photoreceptors in the eye. And then the pointer's not working. But you see the sort of third line up from the bottom that just bumps up a little bit in the middle. That's the photoreceptor layer. We call that the ellipsoid layer, okay? And it's, when you look at it, you want to make sure that the photoreceptor layer is right next to the RPE, okay? Anything that separates it is not good because those photoreceptors will start to die. So if you get some fluid that leaks between the two, even if you get rid of it, some of those photoreceptor cells die, then you connect it back again. So you end up having repeated little insults every time it happens. So when you're using a scan, we zoom in on those tram lines at the bottom and look for any breaks in them. Normally, those tram lines in a healthy retina, they look like that. They're very sharp and clear, really distinct, really easy to see the differences between the different layers. That tells you it's healthy and it's working well. When it doesn't look like that, the RPE is starting to break down. It's very hard to tell. It gets quite bumpy and grumpy. It's quite a thick line. It's not clear at all. So diagnosis and referral. So early AMD, you confirm it with a slit lamp and you confirm it with plus or minus OCT if you've got an OCT. And we don't really want people referred in to the hospital eye service if you've got dry AMD. Hopefully, we'd all be in a place where we're comfortable enough to talk about nutrition, smoking, diet, looking after themselves, protecting their eyes, giving them an AMSLA grid or whatever monitor they can use. And that SOS return is the thing we always talk about as well. So, so what do drusen look like on an OCT? So if you remember, I said look at the tram lines at the bottom. So you can see it's quite bumpy, it's not clear. So it's clear and sharp off to the left and the right of it, but in the middle, you've got those bumps. We know it's drusen because drusen are full of material, and those bumps are all hyper-reflective. So hyper-reflective means there's material in it. So they're drusen. That's what drusen look like on a scan. This patient's vision, they might complain of a bit of distortion, but they'll still be in the early stage. They'll be 6, 7, 5, 6, 9, that kind of level of vision. So, you know, if you've got a patient that turns up with metamorphopsia, but the vision's okay, and you're worried if it's dry or wet, you can pop them on the OCT and it'll tell you straight away whether it's dry or wet and whether they've got drusen or it's not drusen. So it really makes a big difference. So we do see lots of referrals into the eye hospital where people are referred in for this situation. The patient's got new symptoms and they've noticed that the metamorphopsia in their vision, but actually they're dry. And we haven't got anything we can do in the hospital you can't do in community for these patients. Late AMD, we've got, again, confirming with a slit lamp and an OCT, if you've got an OCT. And you'd only refer those in, and it might not be to the hospital, it might be to a different pathway now. If they've got sight impairments, they need registration from an ophthalmologist. They might need low vision support. They might need ECLO support. Everybody got an ECLO? Everybody know what ECLO is? Eyecare liaison officers. They're sort of scattered around the country. They're not everywhere. They're funded often by charity, by the RNIB, but they are effectively like a social worker for people with visual problems. So they are very good at signposting different services for people. They're very good at organising registrations. They're very good at referring them to low vision units if they've got one, or home domiciliary low vision units. So ECLOs are fantastic. Really, hopefully we get one everywhere, but they're really patchwork quilt at the moment. So, and if they've got new symptoms, so just because they're dry doesn't mean they can't develop the wet. So if they then suddenly develop new symptoms of drop in vision or increased distortion, again, you'd refer those in. Going back to the dry and the geographic atrophy, again, using the OCT, you can see this fundus image on the left. There's a big patch of atrophy in the middle, and that's what the scan looks like. So again, if you're using my kind of rule of thumb, following the tram lines, if you follow them along from the left, they're there, then they completely disappear, and then they only start again back over to the right. So, and that bit in the middle, you can see all the retinal tissue has disappeared, completely gone away. So you've got all the retinal layers are gone. There's no RPE, there's no photoreceptors. Okay, so the potential for vision is very low. So you're looking at 660, 6120 in the patient like this. And in fact, actually, you can see all the choroidal blood vessels underneath where, because there's nothing to bounce the signal back up as it goes through. So wet active. So wet active AMD, we want that seen quickly. So if you've got a patient that you think's got wet active AMD, we tend to get that referred somewhere. It's not an ocular emergency, but it's a rapid access thing. You need it triaged and looked at quickly within a day or 2 days, ideally, and referred into the eye hospital. We don't tend to use FFA on most wet AMD patients anymore. The NICE guidelines changed last year. We don't have to do that anymore. You don't need to do it. If there's a puddle of fluid under the retina, you know there's a membrane. You don't need to go injecting a dye into the arm and taking loads of photographs to work that out. You can see the fluid, so you don't need to. So in many ways, OCT, again, has been a real leap because it lets us treat the patient quickly. You know, if you think about, so our clinic on a Monday afternoon normally has 60 to 70 AMD patients into it. So if I had to do FFAs on all of those, it takes 15 to 20 minutes. You need nurses, you need photographers, you need anaesthetists, you need other people standing by just in case one of them has an anaphylaxis reaction and needs to bring them back to life. It's very rare, but it can happen. So it just it's just untenable, it doesn't work. So OCT has changed that for us. It helps us look at that fluid, great, we can treat it as wet AMD and start, and away we go. We'd offer FFA if it doesn't show, if they've got symptoms and it doesn't show that, or like I said earlier, if it's not responding, if we've treated it 3 times and it's not responding the way we thought it was going to respond, we might do an FFA and an ICG, which is usually in the same process. And if it confirms active, we'll then deliver anti-VEGF injections, which sure you're all aware of the three types. We've got Eylea and Lucentis, and Avastin, which is off license. So what does it look like? That's what it looks like. So can you see the puddle of fluid at the top there underneath? So again, if you follow the tram lines across, the top white line is the photoreceptor layer. That goes up, and the RPE goes down. So you've got a puddle of subretinal fluid underneath the retina. You could probably see it if you look really carefully with a Volk, but it's quite a shallow. You can see the foveal profile is still there as well. So again, OCT in this situation is massive. Makes a big difference in terms of us being able to diagnose this with absolute clarity that we know it's wet AMD. And actually, if you look over to the right, can you see that the RPE gets really bumpy and cruddy? It's not like the really sharp, clear one on the one I showed you off to the left. And that's where the RPE is starting to break down. It's just not working properly. It's not nourishing the photoreceptors. And actually, probably hidden under that bump going up on the right is the membrane that's leaking where the fluids come from. So risk factors. Age, obviously, ethnicity. There's some studies that show that Caucasians are more at risk, although there's a caveat to that in that different types, if you remember the slide about the different types of wet AMD, that's actually, so polypoidal choroidal vasculopathy, which is a form of wet AMD, is much more common in Far Eastern populations than it is in the UK, but we tend to get more of the classic and occult type in the UK than the other way around. So there's a little bit of a caveat on that, but that's ongoing work. If you've got family history, that really cooks your chances badly, I'm afraid. Females are thought to be more at risk, although that's a bit sketchy. There's not massive evidence on that. In one eye more than the other. Macular pigment density is related, again, some evidence, but not massive evidence. We need more studies on that, but it is related to nutrient intake, which can protect. Smoking is a conversation we have with every patient who comes into the AMD clinic about smoking. It's a risk factor. If you smoke, you'll get macular degeneration 5 to 10 years earlier than if you don't smoke. And actually, non-smokers are less at risk. Sorry, people who stop smoking are less at risk than people who are currently still smoking. And you often see people who smoke who've got lots of drusen. They've got, going back to that very first slide, they've got lots of drusen, lots of pigmentary changes in the retina. They haven't got wet AMD yet, but they've got it younger than you normally expect it to be there. You look at the retina and you think, that doesn't look good for a 50-year-old. It's not great. So, and light exposure, and again, cardiovascular disease. There's something like 75 different risk factors if you read some of the studies. So the big studies, like the Blue Mountains Eye study, the ARED study, it's very hard to pick out with detail all those individual risk factors, isolate them, and say there's compelling evidence for it, okay? So the one things we do know, nutrition and smoking, are really big factors. So we talk to every patient about smoking, stopping smoking, and eating the right stuff, having good nutrition. And on to nutrition, the AREDS 2. So the AREDS and the AREDS 2, they produced evidence that taking supplementation or using nutrition helps in certain patients. And it helps patients that are at risk. It didn't look at patients, or found no evidence that patients with normal eyes, so if you might get the worried well, you know, you've got somebody who's got nothing wrong with them, but they're convinced they're going to get something wrong. We all know the sort. And, you know, they found no evidence that it made any difference for them other than just good nutrition generally for their whole health. It does show that there's a 25% in reduction in progression from dry to wet or progression of dry in patients that are at risk. So the ones with medium drusen, the ones with lots of changes in their macula already, it makes a difference with those patients. And the AREDS 2 formula is the vitamin C, E, zinc, copper, lutein, and zeaxanthin. Interestingly, AREDS 2 found that adding long-chain omega-3 long-chain to the diet didn't make any difference. Yet there are lots of other studies that show that that does make a difference and it reduces the effect. So AREDS 2 and AREDS are great, and that's the formula you should always recommend to your AREDS 2 to your patients. Supplementary taking omega-3s is something else. Again, we will always talk about eating oily fish. So conversation we have with every patient is dark green leafy vegetables, curly kale, spinach, oily fish a couple of times a week. Because there are lots of studies that show that it does make a difference, even though AREDS 2 show it didn't make a difference. Okay, so where does that sit in? Like I said, it sits in just there. that's where we can intervene. That's where we can recommend, which are probably all doing that already anyway. So when you've got patients who are at risk of like that, as well as having the smoking conversation, you can talk about supplements, you can talk about nutrition, whichever one it is. Patients will say, well, which one should I do? The tablet, because the tablet's often easier than buying oily fish and eating healthy meals. You know, as a friend of mine once said, you know, boiled spinach is great if it's wrapped in bacon and drizzled in cheese. So, you know, eating spinach and curly kale every day, you know, it's a bit dull. It's not the funnest thing to do. So patients will go for, if I can take a magic pill, great, and I'll just have a load of burgers, then it's fantastic. It just doesn't work like that. So, so they'll often say, which one should I do? So if you can afford the supplements, do the supplements as well as the good nutrition. But, you know, have a good diet change your diet, and then supplement it with nutrition from a tablet if you want to. Don't just take that and eat crap. So as I said, optometry is really well placed. We see lots of these people. We're really good. We've been really good recently at making a message that we can detect eye conditions and prevent lots of sight impairment, sight loss. So we're really in a great place with people to who come regularly to us, especially as they get older. They come for regular eye tests. We can advise them of the risks. We can talk about nutrition. We can talk about the smoking. We can talk about all the other things that we can help protection from UV. And we are ideally placed to educate a public about these things. They can look after themselves. And you know, that's a slow thing. We can't really measure that quickly. But actually, if we do that and we do that well, for all of us do that well, then ultimately 10 years down the line, there will be a knock-on effect because there won't be as many people with developing or progression of AMD, dry, whether it be dry or wet, because we've helped them prevent that in some way. And also, we are well placed, especially with OCT now, to be the referral refinement, to stop all these referrals going in that don't need to go in. So, as I said, our clinic on a Monday has 60 to 70 patients in it, probably discharge 30% of them on the first visit because there's nothing wrong with them. So they've got drusen maybe. And in Brighton, we've had a cozy pathway for the last 8 years, which is a community optometrist with a extra bit of training and OCT. The patients that go through the cozy pathway, they are about 90% specific. So they're either treated or they need monitoring at the end of the eye hospital. The referrals that come from outside of Brighton that aren't through a cozy pathway, we discharge probably 50% of them on the first go. So optometry is in a great place to refine that input into the hospital, to free up space for the people that need to be there. And that's the NHS's kind of mantra at the moment, is the right patient in the right clinic with the right person and the right treatment. And at the moment, we have lots of not of that. We have lots of patients who don't need to be there, so or have been over-referred, or have been referred for a perfectly good reason, but they've gone to the wrong clinic. So there's lots of work optometry can do to help build that gap and refine all our referrals into the eye hospital. So I talked about patient pathways. So early dry AMD, we'd look at advice, reassurance, SOS, return. By that I mean if you notice any sudden change or drop, give them an AMSLA, give them something to look at in their living room, blinds that have got vertical component or horizontal component. Patients with wet AMD, when they get a proper leak, they'll tell you the door frame looks out of shape. It's not that, I've got an AMSLA and it's a little teeny bit different over here. It's not that. It's like, something's wrong. I can see something's wrong once they cover the one eye. If they don't do that, it often doesn't work. So you can give an SOS, you can give them an AMSLA to self-monitor, you can advise them if you think something's different, get to your optometrist, get them to have a look at you, and they will fast-track you in if it needs to be fast-tracked in. Wet AMD is the rapid access pathway, so I said they need treatment in a timely manner, which is within 2 weeks. So that varies from place to place, unfortunately. I wish we had a uniform platform for that, but we don't. But again, if you've got whatever route it is, whether it's fax or email or letter with the patient, get them in, get them treated quickly. Eyecare liaison officer, sometimes you'll refer to them, especially if you've got one, for support, if the patient's struggling, saying they're having difficulty with their life. Low vision unit, we've got a low vision unit. That's not just about magnifiers, that's life skills as well. That's things to help adapt the home so patients don't have falls, okay? So patients, we know there's a whole stack of data that patients have falls. It leads to an ongoing thing where people then end up dying earlier because of it. So, and that's all linked to poor vision, So So ECLO can provide support. Low vision clinic can provide magnifiers and devices for home, for the kitchen, little raised things for your hob, little sound devices for your cup of tea. One of the most common problems people have with visual impairment is burns. And why do they have burns? Because they make a cup of tea and they miss the cup and they burn their hand. So there's a little sound device you can put in a cup of tea or a cup of water, and it just beeps the closer you get to the top, and that helps them and again, we can get that from our local low vision unit. So monitoring it, don't refer it in if it's early or dry, but there's no change in it. Self-monitoring, OCT, we can monitor in the community for us. They're offered anti-VEGF treatment if they've got wet AMD, if we referred them in. The criteria are nice, a 612 to 696. Okay, if you've got an only eye, if we think we're going to get an improvement, we will sometimes treat an eye that's less than 696 because there's a chance of affecting their quality of vision over life. And sometimes you do get people who go from below 696 and then they come back to 648, 660, which to us, when we think, well, God, I've gone from 6.6 to 6.9, it's terrible. Actually, there's a big difference the other way. If they're going from below 696 to 648, that gives a big impact on the quality of life that patient has. So we'll often do that. The 612 thing as well is a bit of an arbitrary thing that they've put in place. And again, there's many a conversation where you can see a puddle of fluid underneath the retina. They're still 6.9 somehow, or 6.9 minus. You'd say, but you did really well on the chart. Do you want to have another go? And try and not be so good this time. As I say, there's a cost-effective part of it. And overall, actually, there's also the risk of endophthalmitis when you inject a patient. So it's about a 1 in 2,000 chance that a patient can develop endophthalmitis post-injection. And that can lead to permanent sight loss. So not just the middle gone, the whole thing is gone. So has anybody seen anybody with endophthalmitis? You got any patients? Not fun. It's really not fun at all. Doesn't end well, ever. It's always usually a really poor outcome with it. So switching and stopping. So again, patients might ask you this sort of stuff. Oh, there's this new drug I saw in the paper, or this cheaper drug that the NHS have now said we can use, or the courts have ruled that we can use. All the drugs, all three of them, are all very, very similar in their efficacy, okay? There's not much change between them. Some of them potentially last a little bit longer, by about 2 weeks, but actually they all come out very, very similar. So there's not a massive amount of benefit from switching from one drug to the other. And in fact, actually, you're on a hiding to nothing. If you switch the patient, and then their vision drops, they'll be like, well, why did you switch my drug? I used to have Lucentis. Why have you changed me to Eylea? So there's very little evidence to show that switching them makes much difference. And we consider stopping if the eye develops progressive loss, like this eye behind it with that great big fibrous scar. We actually involve the patient with a decision and give them a choice and say, well, look, or we can pause treatment. Why don't we pause treatment? Let's see how things go. And then they come back and it hasn't changed again. Or just they're part of their whole care. That's part of their decision about whether we stop treatment or not. So it's a really important conversation to have with them when you do it. And ensure actually that there's, when you finish that process, when you say we're not going to treat you anymore, actually they're still very anxious and they still want to come to the eye hospital for their care because that's how they feel. So there's a route for us to be involved in post-care as well. So from secondary care back to primary care, where we can help and look after. We can be a point of contact for patients who've been treated, who are dry with a scar or have been discharged because they've been dry for 2 years, and they can come back to optometry care. And again, Brighton has a model very similar to that, where patients get discharged back to the cozies. They scan them for the first 6 months or 8 months, but they know they can go somewhere and get a scan, can get treatment, can get advice, can get referred back in if something happens. I think that's really important because people, if they develop a problem, they can then sometimes pitch up at A&E. And if you pitch up at A&E, at the eye department, you might see, with all due respect to a junior doctor, you might see a junior doctor who says, okay, well, I'll bring you back a week Monday to a different clinic. And the time frame might be completely wrong. So actually, it's probably better for them to come through somebody who's had some extra training with an OCT who can then send the OCT across, and they get seen in the right clinic in a quicker time frame then. So it actually makes things worse, funnily enough, by going to emergency sometimes. And the wider visual effects of AMD, so again, from part of our role in helping people post-treatment, or if they've got significant problems, all the things on there, you've got distortion, you've got contrast sensitivity, the glare, the photophobia, that often tell you, out in the garden, come back inside, takes me 10, 15 minutes to be able to see again, because they just can't adapt that quickly. Their photoreceptors just don't change, or what photoreceptors they've got just don't change quick enough. So, and reduced colour vision, and again, all those things can be a challenge for people, especially, again, I go back to the ECLO can help them deal with these things. And difficulty crossing roads, lots of falls, burns, loss of independence, and there's a knock-on effect to family, right? It's a huge effect for family. If you have an elderly parent or relative who's got, who's 696 in both eyes, or has got count fingers, there's a huge impact. You have to bring them into the home usually, probably have to change your home to adapt for that person who's got a visual impairment. So there's a huge piece in this, and we tend to forget that. We tend to diagnose and refer and not think about them post-treatment, which, is a big thing. And Charles Bonnet. So does everybody know about Charles? Everybody's heard about Charles Bonnet? Charles Bonnet is where you have visual hallucinations. It's actually more common than you realise. People just don't tell you because they think they're going mad. Okay? So it's actually more common than you realise. So basically, they've got poor vision, and the brain's trying to make sense of the funny jangled signal that's coming from the photoreceptors, and they've got a memory in their brain, and that's kind of stimulated, and they come up with they see children or flowers or some funny thing, and they know it's not there, but they don't want to say anything to anybody because they think, am I losing my marbles here? And actually, that's one of the key clues in diagnosing it, is that they're conscious of it and they're aware. And actually they know it's not. So it's actually more common than you realise. So you might get people who come along with visual impairment who say, well, I saw some funny things in the garden, if you've got a good relationship with them. So, and there's actually a dedicated charity. The college have a leaflet on it. There's a charity called Esme's Umbrella that deals specifically with Charles Bonnet syndrome and supporting people, because it is difficult. If you were, living on your own, you were seeing these funny things running around in the garden, you'd be worried. You'd be thinking, what the heck's going on here? You wouldn't necessarily think it was your AMD that caused that to happen. So in the future, as I mentioned earlier, so as I said, OCT is more and more prevalent across the UK in all optometry practices now. So there's a role for us to be involved in that referral, refinement, that triage, and post-monitoring when patients are discharged. And that probably could lead to a community care-based model. So, if you think about, I don't know if you know Brighton, but Brighton Eye Hospital is right in the seafront. Parking's crap. It takes 2 hours. You have to move your car every 2 hours. So if you've got somebody from Uckfield or Surrey or somewhere else driving 2 hours with a family member, invariably they sit in the corridor for 2 or 3 hours until we call them through. I guarantee you, every time I call them through, they're on their own because the son or daughter's gone to move the car. Okay, and then you call them in and you tell them, no, I've got to treat you or whatever, and they have to do that on their own. It's not great. It's not great care. So it's the right medical treatment, but it's not great holistic care for the patient. So, so community care, if we can have that connected up in some way with OCT, with models that work like that, is great. In Newport in South Wales, they actually have their injections done off-site. So they're diagnosed and have their first injection in the Royal Gwent, and then they have their follow-up injections in an optometry practice down the road, upstairs. Literally go and it turns into hospital blue lino, but that's where they have all their follow-up injections. So that model's got to evolve in some way just for us to deal with the number of patients that are coming through for treatment these days. Teleophthalmology and AI. AI is a big thing at the moment. Piers Keane at Moorfields is, all over the place talking about his AI platform, his AI development. And, potentially it's very good. It's very early days. Even Google DeepMind will tell you it's about 5 years before this is actually even a viable proposition that we can roll out. But ultimately, that could be built into your OCT. That could be built into your OCT, and when you scan a patient, it will boom, this will come up with, it's probably this, or it's probably that. So again, that's a really good place to be. The problem with AI is you need to have segmentation. So all those layers of the retina I was talking about on OCT, you need to have a clear, sharp image to be able to put the segmentation lines in place. So if you've got a big cataract or loads of corneal scars, you don't get the segmentation and the AI doesn't work. So it's not the be-all and end-all. It's not the magic wand that's going to solve everything. Teleophthalmology is a more up-to-date version where we do scan patients, send it into an ophthalmologist with all the other necessary images and symptoms, and then they will give you a verdict back saying, yes, I want to see that patient. No, you can keep that in primary care. So there are some new AMD drugs. So I was at Retina last weekend, and there's a new wet AMD drug that's got a different mechanism of action that's looking very promising. That's in a phase 2 trial, I think, now, and it looks really like it's more effective than the other 3 we've already got. Still a while for it to come through, but it'll take a while. You've got trial injections around the geographic atrophy. As I said, there's a drug that they inject 2 monthly that slows the geographic atrophy, because that's actually an inflammatory process, and this dampens the complement reaction and stops the GA developing. So again, that's very promising. And there are some new delivery methods. So patients hate injections. They hate coming to the eye hospital to have injections, and you'd be a strange person if you fancied having your eye injected. And so there's a little device which is effectively a reservoir. So they implant it into your sclera, you fill it up full of anti-VEGF, and it just dose releases. And then every 2 months you come back and you fill it back up again. And it works. It's got some really promising results. So there are some really exciting changes coming in terms of us looking after these patients. And actually that means they don't need to come to the eye hospital as often, which again frees up space for the new referrals coming through. So it's good joined up thinking. And then genetic screening, which is again, it's one of the big factors in terms of determining it. Still doesn't mean we can change what's going on, but at least we can highlight the patients that are more at risk and put them in the appropriate care pathway. Okay, I think that's about it. I put some cases in at the end, but we can just do any questions if you want. Anybody got any questions? Yeah.
Mike, I just want
yeah.
Thanks for a very interesting lecture. I just want to check, you mentioned that drug, which is there's research, the fourth potential drug.
Yeah.
Do you know the name of that?
It is called it's called Fancibab. So yeah, and it's really interesting. There was some data presented last week, and the pilot data they presented showed that it's really effective after 12 weeks, probably a bit more so than the others. Again, none of these things are magic cures, but they are if we can reduce. So if you think about the cost of the drugs involved and the burden on the patient and the family and coming into an injection clinic and the monitoring, if you can increase the gap between those visits, that's better for the patient, that's better for the health service, and it frees up space, but also saves money, because if it's like longer acting insulin, I suppose. If you get an insulin acts longer, you don't need as many insulin injections, then actually it's better care. So the problem with wet AMD, a little bit like diabetes, is that it's the fluctuations that cause all the damage. Every time it leaks and then goes away. So we used to treat patients where after the initial loading dose, a lot of them were treated on a PRN schedule, which is you'd scan them, they've got some fluid, we inject. And then if they were dry the next time, you wouldn't inject them. And then you see them again, and then they've leaked again, and then you inject them. And so, but every time they leak, they're losing photoreceptors, okay? So, and now we do what's called treat and extend. So we plan the care, we treat, we plan another injection, another scan 6 weeks later. If the scan is dry, we then make it 8 weeks later, and then 10 weeks, and then 12 weeks, and then we might stop and go active monitoring. So it's a much more managed approach, and they don't leak repeatedly up and down, which again is what happens in, I guess, with diabetes, is you get this peaks and trough, and it causes a bit of microvascular damage every time. So it's a kind of similar analogy, if you like. So longer lasting drugs are great. It reduces the visits to the eye hospital and keeps a better control of their AMD all the way through. Patient compliance is actually pretty good. So you do get some patients who don't turn up for injections, don't turn up for scanning appointments, but they're few and far between. They're pretty good with it usually. If they don't come, it's usually because they've been admitted to hospital for something else. So they've usually developed some other condition. So, generally, if the family are involved in the care as well, and we tend to do that, we tend to involve the family with the whole care. There's a lot of planning around them coming, so they tend to come. They're pretty good with it. So.
In terms of cutting out causative factors?
Yeah, so smoking's a tricky one, isn't it? So you can talk to some people till you're blue in the face and they won't stop smoking. So that's much more difficult to measure in terms of whether they stop. Even if you just repeatedly talk to them, it's going to have a nudge factor. You heard about the nudge factor. If you just keep talking about it again and again, people will moderate their habit a little bit. They will bring things down. And diet, again, most patients that have got AMD, they don't want to go blind. They don't. I mean, that's what they ask all the time. Am I going to go blind? So if you can give them good, strong advice to say, well, actually, eating the right stuff and not smoking will help you try and prevent that, then most people will grab it. So, but yeah, it's a good area to mention because it's not easy to measure that, is it, at all? So, don't know what's going on in their life when they get home. It could be all sorts of things.
Yeah, thank you, Ms. Horler, for a very excellent presentation. You mentioned Charles Bonnet syndrome. Can you elaborate on that? Why was it named after Charles Bonnet? Who is he, or why?
Yeah, good question. I don't know that, actually. I really don't know that. So, the reason I put it in is because I think it's something that's more prevalent than we realise. I think people don't talk about it often. They keep it to themselves. I think if I'm comparing primary care to secondary care, people talk about it more in secondary care than they do in primary care. And when they've got a diagnosis of AMD already, I suppose. So I just think it's there, and people sometimes are reticent to say they suffer from it. So it could be one of a few things that's going on with their vision, but they generally forget about it and they think it's just a funny turn they've had, or that people do all sorts of weird things to make sure it's just one of those things, or I didn't feel very well that day, or whatever. And actually, I think people need to be aware of it more, especially if we're in the community and people can trust us to talk about that sort of stuff. So, do you know why it's called Charles Bonnet? No, I don't. I'll Google it in a bit. Yeah. I'm assuming he's the guy that described it, but don't know. Yeah.
Just want to ask, when you're recommending a lot of supplements, a common question that we get is it safe to use with a medication? Because we get, obviously, lists of medication coming through.
Yeah.
Is it do they have to go to their GP to ask, is it safe, or can you recommend them quite confidently say, look, this is okay to
Well, it
use?
depends a little bit what they're taking, but most people, if they're just taking standard, sort of hypertension, cholesterol medication, all that stuff's fine. The original AREDS formula with the carotene in it was a risk factor for people who smoked, so you must tell them not to take that, but most things are AREDS 2 these days anyway, so there's no major implications on that unless it depends how long the list of medications are, but most standard straightforward stuff, no, you don't need to. So yeah.
Any more questions? I've got one, actually. I've got a couple, actually.
Okay.
How quickly after smoking would the risk factors be lowered? Quitting, rather.
Yeah, I've got a feeling that paper they measured it 5 years later. Okay. But what happened in the 5 years between, I don't know. But I'm pretty sure that was 5 years later. So that's stopping for 5 years. It's really interesting because my dad had a massive heart attack in his 50s. And the cardiologist, the minute he said he smoked for 25 years, the cardiologist went, okay, that's it, and didn't take any other history because he just blamed the smoking for him. Yet he's perfectly healthy and happy now, so, and he stopped smoking. So I don't know is the short answer, but that paper was 5 years. So,
okay.
Yeah.
Okay. Another one also, I'm a BDM obviously for Scope, so we speak every day to different optoms. And sometimes there's a concern for optoms that recommending an AMD supplement, they have, well, put it this way, they have a fear of recommending because of potentially overpromising the results that they might get.
Yeah.
So how would you, with talking to an optom or talking to any of your optoms, how would you overcome that?
Yeah, so you've got to be really clear about it. The evidence only demonstrates a reduction of risk in a certain subgroup, if you're looking at AREDS 2 study. So it's only people with medium to moderate drusen pigmentary changes. That's the only one that the evidence shows it makes a difference to. As I said, there is some other evidence that says omega-3s helps, although AREDS 2 didn't find that. But be clear about the reduction in risk. It's about a quarter, it's 25% less chance. So 25% is kind of tangible in terms of I'm reducing my risk. So you can't overpromise, definitely, but it's certainly something you can use evidence and explain to them the numbers quite easily. I mean, you know, if you think about when you're explaining 1 in 2,000 risk of endophthalmitis for an injection, people grasp that reasonably well. I think, well, actually, that's quite a small number, whereas a 25% reduction in risk sounds like quite a good number to me. So, you know, yeah, I can still deteriorate, but actually, a 25% chance, I'll go for that. That sounds good to me. So,
any more questions? I'll go to Mandy.
No.
Mike, can I just ask you, you showed that there was 2 case studies you've got hidden there. Could you just go through one of them with us? Because it would be useful to see a patient journey.
Yeah, of course, absolutely.
Thank you.
Yeah. Really, I guess it was repeating what I kind of discussed in the talk, this one, for example. So this is a 63-year-old who's reporting blurring of the central vision, slightly wavy appearance, good health, blood pressure, and a heavy smoker. Vision in the right eye is down to 6.9 minus, left eye 6.6, greyed out, complaining of wavy lines in the grid. We'll put the AMSLA on, they've got that going on. So you can see that change in the AMSLA grid, and they're presenting with symptoms, albeit sudden onset or recent onset symptoms. And I guess what you can do, going back to diagnosing it on OCT and slit lamp, is if you look at the picture on the left there, you can see that patient's got drusen. So we definitely class that patient as a sort of moderate risk patient. Yeah, you know, if you think about the size of that drusen, it's much bigger than the thickness of the central retinal vein, and there's quite a lot of area affected with drusen, albeit some of them are smaller. If you then scan it across, you can see, so the top arrow, which is on the picture, is showing you a small little bump at the top there, which is a fairly normal drusenoid bump. But the bigger lesion in the middle, that looks very different. That's a much wider drusen, and you've actually got, it's got some reflectivity in it, but it's also got some spaces in it. And so that would be much more, if that suddenly developed, that would be much more at risk of somebody developing, going from dry to wet. So they really are in a medium to sort of high risk process here of maybe changing from one status to the other. So the problem is, if you refer that into the hospital, what are they going to do? So this is more of a debate question, this one, Mandy. So what are they going to do if you refer that into the hospital? Because the patient probably will want to be referred into the hospital. So is there anything to treat? So there's no subretinal fluid. There's no intraretinal fluid. Everything is below the RPE. So there's actually nothing they can do to treat. So this patient would need monitoring. Now the question is, where do we do the monitoring? Because they've got new symptoms, they've got drusen, they've got things that have changed potentially. So you could, if you were comfortable enough with it, you could monitor that yourself. You could give them the appropriate advice, you give them the AMSLA, you could scan them, you can do regular care on them, or some other places will want that stuff referred in. I think for us as optometrists, we need to get to know your local AMD service very well, because they'll all want something slightly different. But potentially that patient could, because there's nothing different that's going to happen in the hospital to what you do in practice. So the challenge for us is, are we up for that or not? And I don't know. Some people are, some people aren't. Depends how comfortable you feel with it. So it's not be all and end all of it. So
would you just send that back out to the community?
So what we'd do in the hospital is we'd probably see them one more time, and if there was no change, then we'd discharge it back to the community. Yeah, absolutely. So there's nothing to treat. Now, it may be the next time you treat them, it does become wet. But if you think about somebody with a dry macula, and they might have all the risk factors in the world. You don't know when they're going to go wet, so you can scan them every 4 weeks or 6 weeks. They could be dry every time, and then in between they develop wet macular degeneration. So, and actually, what patients do in that situation is they go, "Oh, I've got a hospital appointment in 2 months. I'll wait till I go then." And it's about a month and a half slower than we want it to be. So, patient education, advice, making sure they know where to go if something's different is really important to it. So yeah, something like that, if it came in, we would definitely discuss, monitoring. We'd probably see them again, and then if it hadn't changed and everything was okay, we might discharge it back to community again. So depends a bit on what your optometrist has got in practice. So. Does that help, Mandy? Yeah, okay, thanks. Yeah.
Is there a stage that when does become wet that it can self-resolve in the in-between stage?
So if it leaks and then stops leaking, it doesn't self-resolve. Sometimes you get ones that leak. So there's two bits to it, I guess. Sometimes there's ones that leak, and whenever you scan them, they've always got fluid. But if you don't treat them, it doesn't change. So it doesn't carry on leaking, if you like. It's just like a chronic cyst, interretinal cyst type stuff thing going on. They get tubulations and they get all sorts of changes in the retina. It doesn't tend to, I guess, yes, it does, but usually when they're scarred and they're fibrosed and they can't see anything. So that patient I talked about at the end that's inactive, wet, they've had a lot of wet macular degeneration. We've never treated it, and eventually the whole thing is kind of burnt out, but they can't see anything in their hand movements or count fingers at that point. So, but you don't tend to get a little bit of a leak and then it stops itself and they're still 6'9", 6'12". That doesn't tend to happen. So.
You mentioned that you do less fluorescein angiography than you did before.
Yeah.
Are you doing OCT angiography?
No. So OCT angiography is all bells and whistles. There's lots of noise about it at the moment. So it doesn't actually add anything to the pathway in most patients that you treat. So it doesn't show leakage. So it doesn't replace angiography. It shows you the blood vessel. You know there's a blood vessel there if you want to treat it because there's fluid on the OCT. So what does OCT angiography actually add to you? Not much in our pathway. So it might be useful in atypical CSRs. So a 75-year-old with a puddle of fluid, there's actually CSR. It would help in that situation. Because often those patients, they turn up, they're 75, they've got subretinal fluid, and we start jabbing them in the eye. Three injections later, it doesn't work. And if you can do a non-invasive procedure, then that's always better than doing an invasive procedure. But they're the ones that normally end up in our FFA meeting. Unusual, atypical situations, or wide field diabetics. You've got dropout and you've got diabetic macular edema, that sort of stuff. We don't tend to do. The majority of patients with wet AMD diagnosed on OCT, they're treated the same day. Start the process ASAP. But yeah, it's great. It looks fantastic. Lovely images. I'm not actually sure what it adds to your pathway. So. Yeah. Okay. All right. Lovely. Thank you.
Really informative. So big hand for that.